Hello, friends. In the anatomy and physiology class, that's AMP2, I want to welcome you to chapter 17. We are going to talk about the blood in this chapter. The blood is a connective tissue. It's one of the systems that is very important to our body. The blood occupies the veins, the arteries, capillaries, venules, and arterioles. We are going to look at the PowerPoint slides here and talk about it as we go. I'm going to share the screen with you right here, and then we can look at the slides. Functions of the blood. It's listed here. Transport. It transports oxygen, carbon dioxide, nutrients, waste products to the kidneys, and then outside of the body in a form of urine or urea. It also transports hormones, proteins, etc. The blood is a regulator. It regulates the temperature, the pH of the body, and the fluid volumes, because through blood, the fluid is distributed to different parts or compartments of the body. If you remember and recall in AMP1, we have different compartments in our body. We have the extracellular compartment, we have the intracellular compartment, and we have the interstitium in between the cells. The blood is also functions in protection, because it does have the white blood cells, the immunoglobulins, the complement system, and the clotting factors. All these are found in the blood. Blood components can be divided into two big compartments, as we said, a liquid part and an element part, or a form part. So if you take a sample of a blood and let it stay there or sit for a while in a test tube or any bottle, it will separate into two compartments. The bottom one is the liquid or jelly-like, solid actually, sorry, and a jelly-like, and this is the clotted part of the blood. The top part, which is the liquid part, is the plasma. So it's two components, plasma and form elements. Let's take a look at the slide here. I'd like to show you this slide. Yes, here. So if you take a look at that, this is a test tube where we put a blood and let it stay for a while. So 55% of that volume is going to be plasma, and the 45% is going to be the form elements. Of the form elements, we have white blood cells, which is called the buffy coat here. We have the platelets, and we have the red blood cells. And if you see the percentage here in this diagram, the red blood cells form the majority of the clotted portion of the blood itself. There is about 4.2 million to 6.2 million red blood cells in each cubic millimeter of a blood sample, or a 1 ml of a blood sample. The 4.2 is the normal value for a female, and the 6.2 million red blood cells in 1 millimeter of blood is the normal value for a male. If we went down a little further and split that part of the white blood cell, we're going to find that the white blood cells itself is divided into 5 classes or 5 categories. We have the neutrophils, we have the lymphocytes, we have the monocytes, we have the eosinophils, we have the basophils. Red blood cells, we have one type of red blood cells, even though we have different shapes, but these are not normal. These are due to some genetic variations. Like, for example, we have people with specific type of shape. We call it sicklers, and the cells look like a little shell. So it's a sickle cell. And this is a type of blood cell that distinguish people with a condition known as sickle cell anemia. We have people with around spherical red blood cell, and this is what we call spherocytosis and so forth. But these are not normal shapes. So bottom line here, the blood is divided into two portions: plasma part, which is a 55%, and this is the majority of the blood volume, and we have the formed elements, which are 45% of the blood sample. The plasma itself, what is in the plasma? In the plasma, 91% is water. 2% are other solutes, like what? Like nutrients, like waste products, like what? This is urea, creatinine, and other things that our body needs to get rid of. We call it waste product. And also gases. This is the 2%. The 7%, the remaining 7% of that plasma volume is proteins. And these proteins are three main categories. We have albumins, we have globulins, we have fibrinogens. And I really don't think you should memorize the percentages of albumin or globulins or fibrinogens. But I'd like you to know percentage of white blood cells, because these are important. These are clinically important. The values or the percentages of white blood cells categories: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Why is it important? This is something that we rely on in the clinical practice to find out if somebody is having a high count of white blood cell count, what we call leukocytosis. And that can be due to infection, it can be a cancerous, it can be allergies. So whatever type that is predominant here will determine what conditions is it there. For example, if somebody has a very high number of lymphocytes, the normal value of lymphocytes is supposed to be 20% to 25%, and it's found to be like 80%. And the total count of white blood cell in the body, which is about 5 to 10,000 as indicated here. White blood cells usually is about 5 to 11,000 per 1 ml of blood. So if that number is really exaggerated to, let's say, 50,000 of white blood cells, and of that particular 50,000, the lymphocytes showed to be the predominant, like say 80%, then that might point to a condition known as leukemia, or what we know as the cancer of the blood. In the other side, if the majority was neutrophils, then that might point to infection, like bacterial infection and so forth. This is called differential count. So when they ask for a white blood count, if they suspect infectious condition, if the doctor is suspecting any type of whatever, something that can cause high blood count, then they will ask and request something called differential white blood differential. So this is the importance of knowing the percentages of white blood count. That's only a reason I think I would like you to know the percentage. Moving on, blood, of course, is important for carrying oxygen. As we said, carrying gas is very important for carrying oxygen. High oxygen levels showed red, bright red blood, while low oxygen shows a dark red blood. Blood makes about 8% of our body weight, and we need the blood to transport oxygen. Low blood count or low blood volume due to any form of loss, either functional or really structural, just the volume, like bleeding and accidents or surgeries or any bleeding, cancers, bleeding, ulcers, bleeding, whatever, any source of bleeding, internal or external bleeding, can cause significant blood loss. And this can cause anemia. It can cause hypovolemia. That means a collapse of the blood pressure and the volume of the fluids in the body is lost. It can cause hypotension, which means low blood pressure. It can cause circulatory collapse, which means the whole body will bottom down and low blood pressure, and that can cause a shock, a condition known as shock. So moving on, I want to talk about the shape of the white blood cells and red blood cells. If you take a look at this photo micrograph of human blood smear, it shows erythrocytes. This is the majority, as you see, these red round structures. These are the erythrocytes or red blood cells. Erythrocytes means red blood cells. The other cells are white blood cells, different types. For example, here, this is a neutrophil. See, it got a horseshoe nucleus in the middle. This is eosinophil. It does have that red spotted or red or purple granules. We have lymphocytes. Look at the nucleus. It occupies and fills most of the cell. This is the entire cell. This dark purple structure is the nucleus, and this is the nucleus too. All of them, the dark purple are nucleus. Well, this is the monocytes. Look at the big giant nucleus in the middle. So this is a sample of blood smear showing you different types of cells. There is a little tiny structures here. These are the platelets, and the platelets are responsible for clotting. So basically, red blood cells are responsible or function to transport gases, carbon dioxide and oxygen. Of course, they transport oxygen to the tissues. They take it from the lungs and deliver it to the tissues so the cells can breathe. And at the same time, they take from the tissues, from the cells, the red blood cells here, I'm talking about the red blood cells, they take carbon dioxide and deliver it back to the lungs, where they can be expelled out of the carbon dioxide as a byproduct of cell metabolism. Platelets are clotting factors. They help to clot when there is a bleeding or a cut or any form of injuries. They stop and seal the bleeding by forming layers of materials that can seal and stop the leakage of blood outside of the vessels. On the other side, white blood cells are cells that defend our body in different ways. We're going to talk about that more in details when we talk about the immune system. I'm just going to go quickly over some of the slide that I think is important. The other ones, probably you read it already or you're going to read it, and it's a straightforward, self-explanatory. So if we talk about red blood cells a little bit more, as we said, they're gas transporters. So what transport the gases in the red blood cells? Inside the red blood cell, which is a bag that have inside it molecules known as hemoglobin. These hemoglobins are molecules that have two portions, an iron, which is the heme, because heme means iron in Latin, and then the globin, which is a protein. So it's a combined molecule. It's a protein and an iron that has the ability to bind reversibly with oxygen. What that means? It means the hemoglobin has the ability to tightly capture the oxygen where the oxygen concentration is higher, like where? In the lungs. In the lungs, you have a higher concentration of oxygen. So the hemoglobin molecule will tightly hold on to the oxygen and then deliver it to the tissues. On the tissues, the hemoglobin will let go and deliver the oxygen to the tissues, because in that area, the hemoglobin concentration is very low. So when there is high concentration of oxygen, hemoglobin binds oxygen very tightly, as in the lungs. Whereas when there is low oxygen concentration, then the hemoglobin loosely bind to the oxygen or let go of the oxygen so it can be delivered into the body or into the tissues. Talking about hemoglobin and red blood cells and blood, we're going to talk about anemias. So what are the anemias? Anemias are conditions where there is low blood volume, less blood volume, or low count of red blood cells. I'm going to move on, talk about right away to about the anemia here. Anemias, as we said, low red blood cell count or low hemoglobin concentration. What are the symptoms of anemia? It's a symptom of fatigue, pallor, that the person looks pale, and the pallor can be detected in the mucous membrane, in the palm, the hand. You just put your palm and compare it to somebody else. Assuming yours is normal and the other person has anemia, you're going to see the difference in the color. Some people do look in the conjunctiva, like open people's eyes and look at it. I don't think that's a good site to look for anemia, especially in Wisconsin when we have a lot of allergies, where the conjunctiva can be irritated and they can give you a false impression of good hemoglobin or a good blood concentration, because it's just red while the person might be anemic at the same time. What are the causes of anemia, as we just said and worked it out? Blood loss or not enough red blood cell production. Red blood cells are not produced really well, and as we have seen in this other previous slides, I expect you to go back and look at it, where red blood cells is manufactured or made. This is called erythropoiesis. So red blood cell is not made there. This is a condition that might result from different causes. The general name for it is called bone marrow failure or bone marrow aplasia. Or aplasia. That means the bone marrow is not able to produce red blood cells. And this is the size, these are the factories, because red blood cells are produced in the bone marrow of flat bones, like hips, ribs, skull, and so forth. It's not produced in the long bones. And that's why if somebody is having some blood disorders, and they went to the hematologist to diagnose their condition, they might need to take a bone marrow biopsy from their hips to diagnose. Also, if there is too fast or too many red blood cells being destroyed faster than usual, that can result in anemia. This is known as hemolysis, and the condition is known as hemolytic anemia. Usually the red blood cells will live for 120 days. After 120 days, they're supposed to disintegrate or die. And then where do they go? They go to the graveyard. And where is that? That is the spleen. This is normally takes place in 120 days. But sometimes if there is a condition where this is going faster or rapidly than it should be, this is known or called hemolysis. And in this condition, is gonna cause anemias. Here's some, is on a slide that show you some types of anemia. This is a slide that's showing you iron deficiency anemia. That's another cause for anemia. So to be more organized, let's talk about types of anemia. We knew the major causes of anemia in the previous slide, as we said: blood loss, not enough production, too many destruction. Now we're going to go into the details, how that's going to happen. Iron deficiency anemia, and iron is an important element for making hemoglobin and producing mature, healthy red blood cells. If there is no enough iron, like in poverty, not eating well, people don't like to eat vegetables or red meat and stuff like that, and not taking iron at the same time, or pregnant women, or malnutrition, and all these conditions can produce iron deficiency anemia. The red blood cells look like this. They're pale in the middle. They look just like a ring here. Treatment is iron supplement. Pernicious anemia, this is another type of anemia. It's an autoimmune disease that destroys the stomach mucosa. And what that has to do with the anemia? Well, in the stomach surface, there's a protein called intrinsic factor. This protein is important for the absorption of B12. And what B12 has to do with the blood? B12 is another important element for making red blood cells. So if the person doesn't have enough B12, vitamin B12 in his body due to pernicious anemia, or because part of his stomach has been removed due to surgery, then they will develop a condition known as pernicious anemia or megaloblastic anemia or macrocytic anemia, where the red blood cells look so big. If you look at this one here, look at the arrow, compared to the other ones, it is bigger in size. Also, another form of megaloblastic anemia, or megaloblastic simply means large red blood cell. It's a large cell anemia. So they can develop that also due to deficiency of folic acid or folate. So that can also produce megaloblastic anemia. Another type of anemia is anemia of chronic illness or anemia of chronic renal impairment. And this is caused by lack of what you call erythropoietin. And the erythropoietin or erythropoietin actually is a hormone that is produced by the kidney and is very important for the maturation of red blood cells. So patients with kidney impairment, or what we call chronic renal failure, their kidneys are destroyed enough that they're not able to produce this hormone, the erythropoietin. So they start to develop this type of anemia that is only responsive to the injections of erythropoietin. It comes in a form known as EPO, and it's given with the every time they go to the dialysis. Aplastic anemia, I talked about it in the beginning a little bit, and this is caused by destruction or inhibition of red bone marrow. This can be caused by many things, drugs, chemicals, radiations, or viruses, or even cancer. There is some cancer that infiltrate into the bone marrow and destroy the bone marrow, so the bone marrow will not be able or capable of producing more or producing red blood cells. This can be temporary or can be permanent. Some medications, some antibiotics, good example is chloramphenicol or tetracycline, or even some form of macrolides, septrins, Bactrim. All these types can cause transient inhibition or transient depression of the bone marrow, and that can lead to aplastic anemia. Hemolytic anemia, we mentioned that, and this is due to excessive red blood cell destruction. There is many causes for that. First, big one is incompatible transfusion or infection. Like somebody got the wrong blood group, and then his blood will be destroyed, and that can lead to anemia. Infections can cause hemolysis, hemoglobin abnormalities like due to genetic disorders like thalassemias, sickle cell anemias, like spherocytosis. All this can produce anemias. And here they're talking about the types of it. I'm not going into the details. I'll let you read about it. I want to say something about the sickle cell anemia. Why does it result in a sickle cell anemia? Actually, when we want to make, or our body wants to make hemoglobin, it needs specific types of amino acids. One of these amino acids is called glutamine or glutamic acid. In patients with sickle cell anemia, glutamic acid is replaced by another amino acid that is not compatible, and it's called valine. Good example, I'm just going to give you a very simple example in our life. You want to make a table. Let's say this is the mouse using for, I don't think it's showing up here. Let's give an example of a table. Say I want to make a table, 4 legs and a top, countertop. I can make a table with 3 legs of the material that I need, but the fourth one can be something loose. It still can function, but it can be deficient. So that table might fall any minute if it was subject to some stress, because we did not use the proper um, ingredient or the proper third or fourth leg. So that table is incompetent. The same is with a sickle cell um, or the red cell of a sickler. That cell is deficient because the amino acid we use is not compatible and is deficient, or it's weak. In what term? Usually it's fine, but if that red blood cell was subjected to low oxygen or to infection or stress or exercise, then it tends to rupture, just become very fragile and rupture and release all the hemoglobin out, and it can cause jaundice at the same time, and can cause anemia as well. It's gonna go faster here and touch a little bit on the leukocytes or red white blood cells. I mentioned something in the beginning about it when I kind of went over the types of cells, blood cells. Of course, white blood cells or leukocytes, they work to defend our body. These are the defense cells. They defend against diseases, against infections, microorganisms, viruses, cancer cells, and so forth. And just to go over quick about the different types we talked about, we said neutrophils, eosinophils, and basophils. These are known as the granulocytes because they have granules inside the cells. So what distinguishes these three types, the neutrophils, the eosinophils, and the basophils, is the presence of granulocytes. The agranular white blood cells is the two remaining types. These are the lymphocytes and the monocytes. They do not have granules. So again, just to summarize, the granulocytes or the granular white blood cells are the neutrophils, the eosinophils, and the basophils, while the agranular are the lymphocytes and the monocytes. Here some diagrams showing you the shapes of neutrophils. And look at the nucleus, as I said. The nucleus is multi-lobed, got more than 2 or 3 lobes. And if you see there, they got some granules in the cytoplasm here. Look at the cytoplasm, it got some little dots in it. Here, the 5 of them with a very clear description. I like this slide better. If you take a look at it, it shows you each one of these white blood cells category with the description underneath. So neutrophils, eosinophils, basophils, lymphocytes, and monocytes. I recommend to read them and understand them because these features simply help you to distinguish which of these is which, like which one is the eosinophils, which one is the neutrophil. Excuse me. So identifying these white blood cells types is very important. It's very useful for you to distinguish between the different types of white blood cells, as we said. Moving on, not gonna go in details. I'll let you read it. I'm going to move and talk about white blood cell disorders. What are the disorders? We talked about the disorders of red blood cells, or mainly talked about anemias. This is the most important thing. You hear about anemia a lot. So I'm trying to focus on things that you see more in life, in your practice. You see more anemic patients than patients with thalassemias or stuff like that. You see people that needs blood all the time, so it makes sense that we focus on that. Here talking about the leukocytes disorders, and as I said again, I want to remind you, leukocytes are the white blood cells. What are the disorders? Overproduction is number one of abnormal white blood cells, and this is known as leukemias, or an infectious mononucleosis. Infectious mononucleosis. The white blood cells are either increased in the amount, this is known as leukocytosis, or they are very low in the count, abnormal low white blood count, and this is known as leukopenia. And the leukopenia can be caused by drugs, medications, I mean antibiotics. When I say drugs, I mean medications that are either anti-cancer drugs or glucosteroids, or sometimes can be caused by antibiotics also, or increase in the amount of white blood cells as we see in leukemias. And this is a cancer production of abnormal white blood cells that are really immature, they're too young, and they're corrupted, and they cannot do the work, so they're not able to defend the body. That explains why patients with anemia are really susceptible to infection. They get infection more than anybody, even though they have a lot of white blood cells circulating in the blood. You would imagine, like, yeah, they have a lot of white blood cells, so they can defend the body. No, actually, it's the opposite, because having too much white blood cells that are corrupted or immature or not competent, it doesn't do any good. Actually, it prones the body to infection and make him very susceptible to different types of cancers or viral infections. And this is a type of leukemias: myeloid leukemia, lymphocytic leukemia. And these two types can be either acute, that is quickly advancing, or chronic, which is slowly advancing. By the way, the chronic or slow advancing leukemias are less harmful than the acute. Acute leukemia is really toxic. They affect younger group. They tend to cause more harm. They can cause more damage. What we call they have high mortality rate. So the death rate is higher in acute leukemia than in chronic leukemias. Platelets. This is the third type of blood cells that I'd like to talk about a little bit. And these are known as thrombocytes. And actually, when they first the scientists discovered the platelets, they called them thrombocytes because they didn't know what to call them. So they call them fragments of the blood. And that's what the term thrombo means. It means fragments, fragmented clots. The normal amount is about 150 to 150,000 to 400,000 per 1 ml of blood, per 1 ml of blood. They form temporary platelet blood that helps heal any broken blood vessels, and it's regulated by the thrombopoietin. The platelets, as I said, they help seal damaged vessels. Low count of platelets is known as thrombocytopenia, and it can cause bleeding tendency. It can cause bleeding tendency, or it can cause severe bleeding. So if somebody cut his, they don't bleeding does not stop fast enough, like in a regular person, in a normal person. Talking about homeostasis, which simply means stopping the bleeding, that's what you call. There is 3 steps. Whenever an artery is cut, or there is a damage or a cut in our body, 3 reactions occur at that site. Number 1 is vascular spasm. vascular spasm means any blood vessels, if it's tiny one, capillary or medium capillaries, or even a big artery, they will undergo some spasm. So they kind of contract. They contract to make that gap smaller. So if this is my, is this, let's say the distance between the two fingers between my thumb and my index, there's a cut. When there is a cut, the spasm will try to bring the edges together and make that cut narrower. And this is simply done by the smooth epithelium that lines the arteries. If you remember in AMP1, we talked about connective tissues, and we talked about what type of connective tissues we see in the arteries. And we all agreed that in the arteries or the arterioles or the capillaries, there is a smooth muscle that lines up these arteries. So whenever there is a cut, these smooth muscles contract and they try to bring the gap together. The second step is the platelet block formation. So platelets will come to the site of the injury and try to seal that site by making a block that's getting on top of each other and forming that block that seals that injury and prevents blood from leaking outside of that injury. The third step, which is a little later one, is the coagulation. There is a coagulation cascade that will start, and this will bring about series of reactions. And these series of reactions are aiming to produce the permanent seal that will seal that gap and prevent further leakage of blood. So these are the steps. Here's a vascular spasm, platelet blood formation, and then this is the cascade. One of the things that is important here I'd like to talk about is serotonin and thromboxane A. And these are two elements that enhance vascular spasm and platelet aggregation. So what they do, they help these two elements, the vascular spasm and the platelet aggregation, serotonin and thromboxane A. I would like to tell you something, that aspirin is used as anti-platelet. It's used to prevent clotting. If you remember, see grandma or your dad or your mom, they're old enough and they're taking blood pressure medicine or diabetic medicine, whatever. Most of the patients with these chronic illnesses, they're advised to take aspirin as a preventive for clottings, to prevent strokes, heart attacks. How does it work? Aspirin is anti-platelets. Aspirin works as anti-platelets. What it does, it actually works against the thromboxane A, this element. This element is prevented by the aspirin, and that's how aspirin works to prevent formation of clots or the formation of platelets aggregation, as simple as that. So aspirin is effective in preventing strokes and heart attacks. As we said, coagulation is a cascade or a series of reactions that occur since the first step, cut in the blood vessel, and that will expose some clotting factors will come out. And then this will lead to different reactions. And these reactions are numbered from 1 to 13 in the order of discovery. Vitamin K also is needed to sensitize these factors. So here's the steps. If you see here, you got the vascular spasm. There is a cut. This diagram is a really nice one. And then the platelet blood formation. And then the platelets will release chemical that makes nearby platelets sticky. And then the coagulation cascade will start. There is two pathways, intrinsic and extrinsic pathways to form the clots. If you look at this, either of them, they usually are initiated and they're triggered by tissue damage. And then all of them will end with the activation of factor 10. It doesn't matter where they start. Some of them start from outside or inside. So from inside or outside the blood vessels. And then factor 10 will become, will form a complex with calcium, and platelets factor 3. And then factor 5 is formed, which is called prothrombin activator. And this will lead at the end to the blood formation. Here's the steps. I'm going to let you look at it at your own pace. And here's a nice diagram that shows you how each starts. This is the intrinsic pathways, and this is intrinsic, and this is extrinsic. And they both end by making a prothrombin activator, and the prothrombin activator will form the blood. There is the clotting factors that are involved in this process are made in the liver. This is important to know. So the liver makes these clotting factors. So in liver diseases like liver cirrhosis or liver failure, these patients of liver diseases tends to have bleeding tendency. And this is simply due to the fact that clotting factors are not manufactured by the liver because the liver is sick. So the patients tend to have bleeding tendency. This is a nice, look at that nice mesh made by all these factors together. Look at the white blood cells, and red blood cells, the fibrinogen, and it's laid down the thread. So it's kind of helps to seal and to repair that cut area and stop the bleeding. This is a table that's showing you blood clotting factors. I don't expect you to memorize it. Just take a look at it. I don't think it's important for you to memorize them and know all these factors. I do not require that. This is as far as talking about bleeding tendencies and disorders of homeostasis. There is some phenomena I'd like to touch base on, like the clots, how they are formed, what do they do? These clots develop inside our blood vessels, and this is what we call thrombi. So the thrombi are clots that develop and persist in unbroken blood vessels. They don't need a cut or an injury to the blood vessels. They just are formed from inside. We don't know why. There's some people that have tendency for clots formation. Some of them are taking some medication that might cause this. One of the medication that might cause clotting or thrombosis is the contraceptives, or well known to cause that. There is some other medicines that can cause, and sometimes it just is not known. So the risk factors are atherosclerosis, which means the arteries are harder and rigid, or inflammatory conditions, or areas where the blood is slowly flowing or stays is what you call stagnant, is not running from immobility. Like somebody's riding a plane for long hours and he's not moving, or somebody's bedridden, something like that. These are patients that tend to have clotting tendency to make clotting. Medication that are anticoagulants, the aspirin, the heparin, the warfarin or the Coumadin, and others. These are medications that are used to stop the clotting tendency in our body. Blood transfusion. This is another thing that you see in the hospitals, probably. People need blood, need to be transfused to blood with blood due to different reasons, either for surgery, they're needing surgery, or they're very anemic, or during labor, whatever the reason is, they need to get some blood to support them. So we need to give them the right blood group, and that's why we have blood grouping techniques that we use to find out what is the blood group. So we give the person the right blood, because giving the wrong blood can be disastrous, can cause really bad reaction that can cause hemolysis, it can cause shock, it can even cause death. So what to do that, we call it blood grouping, and we have basically 4 blood groups. We have blood group A, blood group B, blood group O, and blood group AB. And of these, the 4 of them, we have either positive or negative. How is that determined? Let me tell you the story. We found out in human red blood cells, there is some antigens or proteins on the surface of each of the red blood cells. These proteins are so unique to the people. People share similar proteins. So we name these proteins protein A, protein B. So people who has that protein A on the surface of red blood cells, we call them blood group A. Those who doesn't have it, have another protein that we found is different, we call it B. And then people who are having that protein on the surface of the red blood cells, we call this group blood group B. We found out there is a third group that has both of them, has protein A and the protein B on the surface of the red blood cells. We call this blood group AB. Guess what? We found out there is another 4th group that doesn't have none of those. And we call this group blood group O. So we have blood group A, blood group B, blood group AB, and blood group O. Later on, we found out that there is another factor or a protein. We called it rhesus. They called it rhesus because I think they found it first in the rhesus monkey. So they found it on this rhesus monkey. So they called it rhesus factor. We found out of all this group, there is some people who does have this protein, the rhesus protein, the rhesus factor. And these people who does have this protein, we call them positive. So if a person has a blood group A, but he also or she also does have the rhesus factor, we name this group as blood group A positive. But if that person does have the regular proteins, A or B, or both, but he doesn't or she doesn't have the rhesus factor, then we call this group blood group A negative or AB negative or B negative. It depends on what type. So the negative and the positive is due to the presence or absence of the rhesus factors, while the ABO is due to the presence of the proteins on the surface of the blood. So to get the right blood group, if somebody is supposed to receive blood transfusion, he needs to get the right group in terms of right blood group, ABO, right rhesus factor, right? Given the wrong blood group is called mismatching and can cause really severe reaction, hemolysis. Here's an example. For example, if somebody is a blood group A, then this person can take only blood group or a blood from somebody who's group A. But he can also take a blood from somebody who's blood group O, because don't forget, blood group O doesn't have none of these proteins on the surface, so it's okay. His blood can be welcomed by any other groups. And that's why people with blood group O are called the universal donors. And the other side, if you think about a person with a blood group AB, so he does have both protein B and protein A on the surface of their red blood cells, these people or persons can receive blood from any other group. They can receive it from A, they can receive it from B, they can receive it from O. So they are known as the universal recipient. Isn't it? It's a table showing you what's going to happen if somebody got a wrong blood group. Simply, if a blood group A was given a blood group B, then of course his blood is going to attack that and treat it as an enemy and destroy it, and that what can cause hemolysis and severe jaundice. You don't see that in nature in real practice now anymore, because we're getting better and smarter in the screening and sorting out of blood. But you see it sometimes in a condition known as rhesus incompatibility, or what you call, they have a name for it. They call it erythroplastosis fetalis. This is simply is a baby in his mother's uterus. The mother has a different blood group than what he does have. Usually the first baby survives. Second baby does have the same blood group. So his mother blood might form antibodies, and these antibodies can stay for a long time. So if she got pregnant again with another baby with the same blood group, then probably that baby's blood is going to be attacked by the mother's blood or antibodies. I think there is a nice diagram here that I can share with you. Here we go. So this is, look at that. This is the first baby, first pregnancy. The baby is does have rhesus factor, so he's an Rh positive. The mother is Rh negative. She doesn't have that, so she doesn't recognize it. So she's gonna make antibodies. Again, that rhesus like, I don't want that. And this baby will be delivered fine. He will survive, running away, getting away with it, leaving his mother with antibodies. We call it anti-D. Next pregnancy, and for if that baby is unfortunate and has the same Rh positive, then that antibodies in his mother's blood that has been formed years ago will be activated and will attack the red blood cells of this baby and cause severe hemolysis. These babies will be born with jaundice, deep jaundice, and they need to stay in the nursery department. They might need something called exchange transfusion. It might just be mild. That might just be put in an incubator, and the condition will be dealt with. So this is one of the ways we see mismatching of blood transfusion. I hope that helps and explains a little bit in the hematology. Thank you.